Good evening, and thank you, SOMAG and organizers for this opportunity. Standing between banquet dinner and end. But but yeah, no, but most of the what I wanted to present has already been answered by Raghu and the discussion we had already. I think Vesa called me to talk on this drug elution. I said, frankly, I don't do any drug elution. So he told me I don't talk about not using drug elution. I thought, okay. So it's an opportunity to pull up our own data and just discuss in meetings like this. So basically what I did was I just pulled up my own SFA data of last 3 years and I'm just going to present my data. It hardly takes 5 minutes. So basically in India, when you think about POBA, we think about simplicity, availability and affordability. And especially I come from Kerala where people are very, very cost conscious and they are very much conjuice about when it comes to health, medical treatment. They will spend on anything else but not on health. And so I thought we'll just evaluate our SFA intervention. So our institutional practice is basically we do POBA as much as possible and it's plus minus stenting in only major dissections. And we just follow the patient with clinical outcomes. Most of the time we don't do duplex in all patients as most of us do. Feel the pulse, check the ABI. Only wound healing is bad or something, we again recheck and do some second angiogram, etc. So technique is standard, like we go antegrade in most patients, use vert and all those things, cross intraluminally as far as possible. Otherwise, go subintimally, do POBA with 4, 5, 6 mm semi-compliant balloons and sometimes even NC balloons also of late in calcific arteries. Use of stents, basically calcified arteries, we rarely use cutting balloons or scoring balloons. And if there is flow limiting dissection and definite recoiling, we use stents ranging from self-expanding, usual whatever is available in the cath lab. I'm not very specific about any particular stent, even sometimes a covered stent, graft mask, coronary stents, etc. And technical success parameters is basically based on the flow in the angiogram suit, and if there is palpable pulse, I'll be more than happy. Post-procedure, put patient on dual antiplatelets, select use of DOACs, but I tend to use prostaglandins in many patients whom I think results are suboptimal. I don't know whether that influences my outcomes. Follow-up is basically by wound healing, palpable pedal or popliteal pulse after SAV intervention. So going to my results, like over last 3 years, we just did around 100 cases of SFA angioplasty, which includes isolated SFA as well as SFA plus iliacs and SFA plus tibials. And basically, most patients come for follow-up. We have got reasonable good follow-up culture in our patients. And those who cannot come, we call them up to at least find out whether they're alive, the limb is safe, so healing, etc. And we got 91 in follow-up. These usual demographics like more males, average age of 67 years, diabetics mostly, etc. So access, as I told, mostly ultrasound guided. Only 5 cases retrograde, almost 86 cases we went antegrade, and of which 39 CFA puncture, 46 SFA puncture. We do little bit SFA puncture also in our SFA plasties. Average length of lesion, I just looked at, it's not bad. About less than 5 is 31, and we had good reasonable spread of length of lesions in the SFA bed. Immediate success is actually in almost all patients except one, we could cross the lesion and do some plasty. We stented only around 20 patients, that is around 21.9% of this series. Stents used, as I told, nothing specific to any company, whatever is there in the cath lab, I tend to use, like Absolute Pro Epic, Everflex, one graft master, and one coronary stent in a small SFA in a female patient. Follow-up, we had decent follow-up of around ranging from 12 months to 36 months. We had to do bypass in one patient after POBA. 15 patients died due to unrelated causes, 3 major amputations, and wound healing achieved in 94.6%. And Kaplan-Meier, actually, I just pulled it out last week, had a decent survival curve at 24 months. Actually, the difference between the statistics which we see in the studies which have been quoted here is that we have most patients Rutherford class 5 and 6 because we obviously don't treat claudicants. And technical success rate is almost equal to almost all the studies quoted here, like 98.9%, and limb salvage is not actually bad. at 94.5%. Like Raghu said, none of the studies actually talk about amputation-free survival. They talk about patency, TLRs, etc., which actually doesn't boil down to patient when they come to us in the clinic. They are just bothered about having a healed wound and they had to be amputation-free. Just looking at just 2 studies, just to highlight what actually are the flaws of these studies. If you look at this one of the major studies, they have got most patients in Rutherford 2. 2 means, I think, mild claudication. 3, disabling claudication. The most patients are in mild claudication and disabling claudication. There are hardly any patient in Rutherford 5 or 6. And that is what the data they're talking about patency. That is, they talk about patency 79% versus 46%, which is actually not clinically significant. And they talk also about target-driven TLR, which also actually practically, when it comes to clinical practice, it's not actually significant. And we won't push our patients to angioplasty because just because they have a lesion, we don't go and put in balloon or a stent. Again, another big study, because this study published data of around 1,400 patients. Again, if you look at this study, hardly any patient in Rutherford 6, just 1.5% of patients in Rutherford 5, most patients in the Rutherford 3, that is disabling claudication, which actually we wouldn't actually treat or intervene in most of our clinical practice. And they also again analyze data like freedom from TLR, primary patency, device-related complication, etc., which actually is not a matter of concern for a patient with CLI. And actually, we wouldn't actually look at all these things. So actually, whatever in the study is not clinically relevant when you talk about CLI patients when compared to claudicants. So in my personal observation, I found that not much data on patient with CLTI, even though I think Chaitanya told me about that. There's one study. I just went through the net. I found that study was particularly about intrapopliteal, not about SFA. So if Basel 3 comes out, that will be the first study which actually deals about DCBs in CLTI. Otherwise, we don't have any hard data about use of DCB in CLTI. And most data does not look into limb salvage as a primary endpoint. They talk about TLRs and primary patency. And in CLTI patients, drug elution might not significantly impact the amputation-free survival rate. This slide was prepared before Raghu's talk, so don't think that I modified the slide after Raghu's talk. So obviously this slide was there. So drug elution seems to have a definite place in claudicants if you want to treat them, which we most of us don't do. And in CLTA patients, I think selected group of patients like treatment of in ISR, redo intervention, and small SFA where you don't want to put stents because SFA is small, you might use DEBs and they may be useful. But if you really ask me, you can use the technology selectively, but you cannot actually prescribe this as a blanket practice for all patients in our scenario, at least in India. So I think with this, thank you for this. I think I rather summarize what we discussed over the day.